Hi friends. So now we're beginning with the integrated GI and hepatobiliary system. Here again we're going to be integrating GI physiology followed by pathology, pharmacology and medicine overall. So the first thing that we want to discuss here is the physiology of GI motility. Alright, so in GI motility there are two things that we got to know. One is the basal electrical rhythm that we have, and then you have the mechanical movements. So just like how we have pacemakers, which do not have a steady resting potential, just like that the intestinal resting potential is also fluctuating, like you can see. Alright, so the intestinal resting membrane potential fluctuates somewhere between -45 to -65 voltage, as you can see in this image, and anytime you have these action potentials, that is where the contractions happen. Yeah, so this BER is what is known as the electrical baseline resting membrane potential of the GI, which is known as BER, basal electrical rhythm. And then wherever you have these spike potentials, that is what corresponds to the contractions, like you can see in this tracing here. All right, now what is responsible? Just like you have pacemaker which also shows this fluctuating RMP, just like that you have pacemakers in the intestine which generate this basal electrical rhythm. And the pacemaker of the GI system, very famous question that we do in the first year also, are the interstitial cells of Cajal. Alright, so these are the interstitial cells of Cajal that we gotta be aware of. Alright, so this is very important. Now you can also see how acetylcholine and epinephrine work. So you can see in whenever we are giving acetylcholine stimulation to this particular intestine, this is again some experiments that we used to do in the first year, right, on the rabbit intestines. Yeah, so you can see how acetylcholine are increasing the spike potentials, and that is what is leading to an increase in the contraction of the intestine, whereas when epinephrine is injected, you can see the reduction in the spike potential and overall reduction in the movement. All right, so this is what is the basal electrical rhythm of the intestine, remember, generated by the interstitial cells of Cajal. Now AIMS/INICT loves to ask you questions on this. In fact, once they had asked you about what has the minimum rate of basal electrical rhythm and what has the maximum rate. So I've highlighted both of those in red for you. You can just see through all of these. So remember, maximum is in the duodenum, whereas the minimum rate is in the cecum, and that would be because the interstitial cells of Cajal are maximally located in the pylorus of the stomach, right? Their maximum density is in the pylorus of the stomach, and that could explain in a way why duodenum has the maximum BR. That's just one way to remember this, okay? So this is about BR. Now, as far as the mechanical movements of the intestine go, there are three things. Two of them are in the fed state for the propulsion of food. So one is segmentation, one is peristalsis. The third movement is what we know as hunger or housekeeping contractions, which are migratory motor complexes. Again, very important for the exams. Alright, so how we divide them in one box? These are for the fed state for propulsion of food, whereas MMC is for hunger. Alright, so these are hunger contractions, or you can also call them housekeeping contractions. Let's talk about the fed contractions first. So segmentation is within one loop of intestine. When you have food, how the food undergoes churning. So basically this is within one intestinal segment. The movement which happens, the mixing movement in a way, is what is known as segmentation. On the other hand, the forward propulsion, let's say this is a food bolus, and how it goes forward is known as peristalsis, as you already know. Now for peristalsis to happen, you need to understand that one segment needs to contract, whereas one segment needs to relax for the food to move ahead. So the ones which are inducing the contractions here are going to be substance P and acetylcholine, which are increasing the contraction, whereas what relaxes the segment ahead is known as VIP and NO. Alright, so VIP and nitric oxide are the inhibitory neuropeptides. Okay, in fact, this is very important because in achalasia cardia also we have seen already in surgery that VIP and NO, the inhibitory neurotransmitters, are absent, and that is why you have failure of peristalsis. There is failure of relaxation and no peristalsis happens. So this tells you the importance of the inhibitory neurotransmitters as well. Okay, so this is about segmentation and peristalsis. These hormones are very important for you to remember. Then the most important, which is MMC, which is migratory migratory motor complex. What regulates this is motilin. Very, very important. Motilin is the main hormone behind the MMCs. These are known as housekeeping contractions because after you've had your meal, sometime around 90 to 120 minutes later, so 1.5 to 2 hours, if you can stay hungry for that long after having a meal, you're gonna have your MMCs beginning, and they are basically gonna sweep through the intestine. They want to clean the intestine of any residual food which is there. So that's why we call them housekeeping movements as well. All right, they're basically cleaning your intestine of any residual food, and you can see how from the stomach to the distal ileum they are progressing. The approximate rate you can remember is 5 centimeters per minute. They progress at a rate of 5 centimeters per minute. Overall, it starts around 90 to 120 minutes after having a meal. This also explains why certain motilin agonists like macrolides, we'll also see this in pharma in our antimicrobials, that macrolides can increase the GI motility, and the action is because they are motilin agonists. All right. So this is about the migratory motor complexes. Remember, they occur in hungry state. All right. So this is about the GI motility. Very, very important. Two concepts, BR and MMC, get you questions. Then we have 3 reflexes that you need to understand. First is the enterogastric reflex. As the name suggests, basically whenever the duodenum is distended, it's gonna ask the stomach to relax. All right, it's gonna make you stop eating because your duodenum is full. So the inhibition of the stomach by the intestine is known as the enterogastric reflex. What are the hormones responsible for this? So 3 hormones: CCK, secretin and peptide Y. These are 3 things which are going to cause this reflex. What stimulates this reflex maximally is fat, followed by protein, followed by carbs. Acidity and osmolarity of the chyme also increase this reflex. So it depends on the kind of food that you've had, how strong this enterogastric reflex is going to be occurring. Alright, so this is enterogastric. Then we have 2 reflexes which are very strong in babies, particularly gastrocolic reflex. You would see that the moment babies have some milk or they have some food, they're going to pass stool. Alright, so that is known as gastrocolic, that the gastric distension is causing colonic contraction. Alright, so this is a positive reflex. So is gastroileal reflex. So basically, so anytime there is gastric distension, there is relaxation of the IC valve. Alright, so that the food passes into the large intestine. Whereas gastrocolic is most common in the sigmoid colon, wherein the sigmoid colon contracts after gastric distension. Alright, so these are 3 reflexes that you gotta be aware of. Now let's talk about the various GI hormones. You usually get one question from this, usually indirect. So need not memorize everything. I'll just tell you the salient points here. So there are basically 7 main hormones that we're going to talk about. Motilin we have already seen. Okay. Now we have gastrin. So gastrin is the main hormone which is going to increase the acid secretion in the stomach, right? So who produces it? Very easy. G cells. Nothing to memorize. It is produced in the antrum of the stomach maximally. Okay. So we have G cells producing gastrin, which increases acid secretion, which increases motility. Okay. This is increased. Positive feedback is by the stomach distension, and the most potent stimulus is by amino acids. So anytime you have a lot of protein, the G cells in your stomach are going to stimulate stomach motility. They're going to stimulate acid production. Okay. Apart from that, vagal stimulation via gastrin releasing peptide also increases it. That's in the name itself. What is very important is the negative feedback. The moment we see that the pH is less than 1.5, the release of gastrin would be inhibited. Alright. So this is an example of how negative feedback works. This is very important. When does it increase? What pathological states? So first of all, if you are taking chronic PPIs, because acid is being suppressed, you are going to have gastrin which is released. So is chronic atrophic gastritis such as pernicious anemia, and Zollinger-Ellison syndrome is nothing but a gastrinoma. So obviously gastrin is going to be increased here. Alright, so 3 conditions in which you have gastrin increasing. Very important. Remember, pernicious anemia, because the parietal cells are destroyed, there is autoimmune destruction of the parietal cells. That is why H plus is not getting produced, and that is why more and more gastrin is getting produced. So this would explain all 3 of these conditions of gastrin increase. Very logical, nothing to memorize. Okay. Somatostatin, focus on the statin, it is blocking everything, it is stopping everything. Yes, so they are produced by D cells. D, stop. All right, so D, remember, is stopping everything, so it reduces everything, no need to memorize. It reduces acid, pepsinogen, it reduces pancreatic and small intestine secretion, gallbladder contraction, insulin, glucagon. So basically everything it is just reducing. Who stimulates it the most? Acid stimulates, because more acid we want to suppress it, and it is reduced by vagal stimulation. So from this, the only thing you want to remember is somatostatin analog. Octreotide I can use anytime I want to suppress any of these. So we can use it in acromegaly, carcinoid syndrome, VIPoma, or variceal bleeding. So these are the indications of octreotide that you want to remember. Then coming to CCK, from this day you are going to remember ICCK. So these are produced by the eye cells. Again, in the antrum, duodenum, jejunum, we have CCK getting released, and what it does, it stimulates downstream pancreas and gallbladder. So it increases pancreatic secretion and it increases gallbladder contraction. In pancreas, what it stimulates is more the hormones, all right. It stimulates pancreatic hormones more than the bicarb excretion, all right. So that is what it increases more hormones rather than bicarb secretion in the pancreas. It increases GB contraction, reduces gastric emptying, and also increases sphincter of Oddi relaxation. So here most important is GB contraction and pancreatic hormones secretion. Again, the most potent stimulus here as well is amino acids more than fatty acids, and this is via the neural muscarinic pathway, cholinergic pathway. Okay, so this next is secretin. Again, very easy, just like G, this is S for S in the duodenum, and this focuses more on bicarb secretion and bile secretion. So secretin and CCK act in conjunction, both have the more or less the same stimulants as well. So here what you want to remember, CCK increases the hormones from the pancreas and inhibits the stomach and increases gallbladder contraction. Secretin increases bicarb and bile and again inhibits stomach. Alright, so these are the two actions of both of them. Then we have GLP. This we have also done in endocrine system. GLP analogs we have studied. So what it does is it increases insulin release and it reduces H plus secretion, and also remember it increases satiety by reducing the gastric emptying. Alright, so it reduces gastric emptying and increases satiety, and it also inhibits the release of glucagon. Alright, so this is our GLP or GIP. Is what you want to remember. Again, everything can stimulate. This is one thing which can be stimulated by oral glucose, fatty acids, and amino acids. So carbs, fats, and proteins can stimulate this. Okay. Oral glucose increases the insulin compared to IV. So the main stimulant here is the oral glucose. Okay. Then we have VIP. Again, VIP is something which is a relaxant. As we have seen, VIP and nitric oxide are your inhibitory neurotransmitters. So they are going to cause relaxation of all of the smooth muscles is what you want to remember. And you have a VIPoma because everything is getting relaxed. You will have a lot of diarrhea which can lead to hypokalemia and achlorhydria here. Okay, then we have ghrelin here, which is gonna increase the appetite. So remember, this is increased in fasting state. Just like MMC, you will have ghrelin which is increased. This is increased in Prader-Willi syndrome, and that's why you have hyperphagia, fat babies, hypotonic babies in Prader-Willi. If you remember Prader-Willi, we have talked about this in biochemistry, where I taught you there is paternal deletion, maternal silencing, paternal deletion in Prader-Willi. Okay, and this also reduces after gastric bypass surgery, so that we have reduced appetite. Okay, so this is about the hormones in a nutshell. Just listen to it once. You know, these are asked in an indirect fashion, more or less, and direct action, you know, very rarely is asked. So once you've heard me out, I think that's about it. Okay. Now let's talk about few one-liners about the GI secretion. So the total volume is around 7 liters per day. The maximum contribution to the secretion in the volume aspect is by the stomach. Alright, so stomach has the maximum secretion in terms of volume. Now, what has the most alkaline pH? This is a repeat question. So these are the Brunner's glands. These are Brunner's glands that we have in the duodenum. Alright, so we have studied this in anatomy and histology, how Brunner's gland are located, and this helps us identify duodenum in histo as well. Okay, so Brunner's gland in the duodenum have the most alkaline pH. The most acidic pH obviously needs no mentioning, but it's the stomach. Roughly the pH is around 1.5, whereas the Brunner's gland have a pH of around 8. Then talking about the maximum potassium concentration and maximum potassium amount. Very, very important that you read the question carefully. In 1 liter of secretion, which has maximum concentration of potassium, that answer is going to be colon. Colon secretions have maximum potassium concentration. But overall, the amount, if we take into account the total volume and we see the amount, then it is saliva. Alright, so saliva has the maximum potassium amount. This is one thing that you should not confuse with. So let's just see the stomach cells. We've already talked about which cells release what, but now let's just see their location. So when we take into account the stomach, remember in the fundus you don't really have a lot of excretion except for the mucus cells. You just have the mucus cells which are releasing bicarb, and they're also releasing a compound known as trefoil peptide. Together what they're doing is they're stabilizing the mucus. So trefoil peptide is a mucus stabilizer. So these mucus cells are the ones which are going to help the stomach be protected against the acid which is being secreted. Okay, so that's the function of the mucus cells. Then in the body we have the main secretory cells. So we have the parietal cells and we have the chief cells. The parietal cells are the ones which are secreting HCl and intrinsic factor. Intrinsic factor is the one which is responsible for binding to B12 and causing its absorption. So this is what gets affected in pernicious anemia. You have antibodies against this in pernicious anemia. So you have H plus which is not getting produced, and you have intrinsic factor which is not getting produced. Then you have the chief cells which are the main cells responsible for pepsinogen. Okay, remember what is the main stimulus of acid? It is gonna be histamine. Histamine is the most potent stimulus for H plus, and this is produced by the enterochromaffin cells, ECL cells that you have, and these are further stimulated indirectly by gastrin. So this is how gastrin increases the H plus secretion via ECL via H plus. Okay, now going to the antrum. So antrum is where you have the G cells producing the gastrin. You again have mucus cells and you have D cells like we saw. So D is to stop. You have somatostatin. Then in the proximal duodenum, you can see these I, S and K. So S is what we remember. S is for secretin. ICCK is how I remember it now. And K cells release the GIP. Okay, so these are the different cells that we want to know. Now, this could be a potential INICET question where they give you these graphs and they ask you to identify what secretion is being shown to you. So, remember, this is the secretion wherein the sodium increases as the flow rate increases. More secretion means more sodium will be secreted into the secretions at high flow rate. Alright, so this is a classic thing that happens in saliva. So, this is how you can recognize saliva, that sodium increases as the rate increases. The next one is the easiest because you have HCl which is maximum. So this is stomach. This is how you can recognize. When you have bicarb which is maximum, this is your pancreatic secretions. Alright, so this is how we basically identify all of these GI secretions. Now let's talk about iron and B12 absorption. So remember this mnemonic iron fist bro, which tells you the parts of the small intestine where each of these are absorbed. So iron, remember, is absorbed in the duodenum, fist for folate which is absorbed in the jejunum, whereas bro for B12 which is absorbed in the ileum. Alright, so iron fist bro, one step down we keep going. Okay, now just for a quick revision, I'm sure you guys remember this. For B12, two main protectors are needed. So the salivary glands secrete this compound known as haptocorin which protects it till the stomach. Okay, so B12 and haptocorin travel in the intestine and this is digested by the pancreatic enzyme. So pancreatic enzyme is crucial for B12 absorption. Yes, so this is one important step where in pancreatitis also you can have B12 absorption which gets affected because haptocorin cannot be removed. Once haptocorin is removed, the intrinsic factor by the parietal cells will bind to it, and with intrinsic factor you will have B12 absorption in the distal ileum. So what do I see here? If there is pancreatitis, B12 absorption will suffer. If there is parietal cells of stomach which are affected in pernicious anemia, then B12 absorption will suffer. And if you have a distal ileum pathology, for example, you have Crohn's disease, you have tuberculosis, or any sort of other disease like Whipple's disease, again B12 absorption will suffer. Alright, so these are the 3 points that you want to remember. Apart from that, for iron absorption, first very important step is Fe3 plus to get converted to Fe2 plus. Alright, so that's the first thing that you want to remember. The transporter is DMT1 on the intestinal mucosa, and then it goes into the blood vessel via ferroportin. Alright, and here you have hepcidin, which is the negative regulator. What happens in anemia of chronic disease is, so this hepcidin is the one which is actually affected and responsible for anemia of chronic disease. So you just want to remember DMT1 on this side and ferroportin on this side for conversion into Fe3 plus, which then binds to the plasma transferrin, and then it basically circulates in the blood and goes to the erythroid marrow. So this is about iron and B12 absorption in a nutshell. Going ahead to acid suppression. So we've already seen how acid stimulation happens. So let's just finish off pharmacology of PPIs right here, right now. Okay. So first of all, what are all the stimulants here? So as we have seen, acetylcholine or vagal stimulation will cause direct stimulation, and it also acts via GRP. Like I said, it stimulates the G cells to produce gastrin. Okay. The most potent stimulus of acid is histamine, which is H2 receptor. So the gastrin indirectly acts via that. So you can see how everything is transferring on to the next one. So acetylcholine stimulates G cell stimulates ECL to produce histamine. So what I can do is I can block these H2 blockers through which indirect cycle is happening. So these H2 blockers are your DIN. So we have simotidine, famotidine, nizatidine, right? Cimetidine is something which is not really used nowadays because it is a very potent CYP inhibitor, and one other famous side effect is gynecomastia. Alright, so gynecomastia is one side effect of cimetidine, because of which it is not preferred much. Then we have somatostatin and prostaglandins, which are actually acting via GI and they are inhibiting the release of H+. What I can give here is actually a prostaglandin analog like misoprostol. Alright, so misoprostol can be given, but there is only one indication. If you are giving NSAIDs, right, if there are NSAIDs induced peptic ulcer, that is because the prostaglandin release is getting inhibited, and that is why you are having more H plus excretion. So in that case, I can give misoprostol. So that's the only indication. But remember, in this also, what is the drug of choice? Drug of choice for everything is ultimately proton pump inhibitor. Let's just block the end pathway. Why go through all of this? Let's just block what is the ultimate result of all of this stimulation. So that is the proton pump inhibitor, which is secreting the H+. So once you inhibit that, you are sorted. Alright, so these are our PPIs, the drug of choice for any kind of peptic ulcer that you have to mark PPI. So omeprazole, lansoprazole, pantoprazole, these are drug of choice for all ulcers, and they are hit and run drugs, meaning once they block a proton pump, then they are inactive for around 24 hours until a new proton pump is born. Okay, the side effects for this are very, very important. So this can lead to Clostridium difficile induced pseudomembranous colitis. It can cause allergic interstitial nephritis. Repeat question, B12 deficiency is one thing, and fracture risk is also increased because it inhibits calcium and magnesium reabsorption as well. Okay, apart from that, omeprazole particularly is gonna interact with clopidogrel because both of them interact via CYP2C19. So this is something that you want to remember, this important integration. Apart from that, what are the drugs that I can use for immediate acid neutralization? So PPIs are going to stop further H plus from getting excreted. If I want to neutralize acid in an emergency, I have to use antacids. So in antacids, what we use is frequently a combination of aluminium hydroxide and magnesium hydroxide. And why that is because aluminium hydroxide causes constipation, whereas magnesium hydroxide causes diarrhea. Okay, so you can just combine the two and net result would be nothing. Okay, apart from that, you can also use calcium carbonate as an antacid, but this has a side effect of milk alkali syndrome resulting in hypercalcemia. Okay, so this is about the antacids. And finally, triple drug therapy. Most commonly, we use 2 antibiotics and proton pump inhibitors. So the most common regimen is CAP regimen, wherein you have clarithromycin and amoxicillin with a PPI is what you can remember. Okay. Apart from that, you have drugs like sucralfate and bismuth also, which can be used, and these are mainly known as ulceroprotective drugs. Okay. So these are just gonna coat the ulcer. Okay, is what you want to remember. So this is about the pharmacology of acid suppression. Now let's talk about pharma for constipation and diarrhea. These are a lot of drugs, and I've seen, students confusing this a lot. So I've just noted down all of the mechanisms that you gotta know. So in constipation, different categories of drugs we can use. Okay, so we can use bulk forming drugs like methyl cellulose, so that's a bulk forming drug. Osmotic drugs include lactulose and PEG. Remember, in osmotic drugs, we also need to increase the water intake, otherwise they can cause dehydration. Okay, so we have lactulose and PEG, which are osmotic. Stimulants, which are stimulating bowel movement, we have senna and bisacodyl. Remember, senna has a very important side effect which can be asked to you as an image-based question. This is known as melanosis coli. So it induces this pigmentation of the colon, melanosis coli. This is a side effect of senna group of constipation drugs. Okay, very important, 2 L's. So chloride channel activator is lubiprostone, whereas guanylate cyclase, CGMP agonist is going to be linaclotide and plicatinide. Alright, so these are your 2 groups of drugs that you want to remember. Chloride channel activator is lubiprostone, and we have seen prostones, mostly prostaglandin activators we have seen. Yeah, this is one way to remember this. Whereas CGMP agonist is linaclotide and plecanatide. Okay, 5-HT4 agonist is a new drug again. This is prucalopride. These are all new drugs. Okay, whereas again a new drug is NHE3 inhibitor, which is tenapanor, which is a sodium H plus exchanger inhibitor. Okay, so that is what is NHE. Peripheral opioid inhibitors can also be given because opioids induce constipation. So we can give opioid inhibitors, but we only want peripheral so that central side effects like respiratory depression and all don't happen. So you want to use this for post-op ileus because opioid is one of the main causes of post-op ileus. So for that we have these 3 drugs. Alvimopan, so here you have opioid ka OP in between, that's how you can recognize. We have naloxegol and methyl naltrexone, and wherever you see nal, it is basically an opioid inhibitor. Okay, so this is how we can recognize all of these new drugs. This is particularly important, and I feel is slightly ignored part of pharma, but you do get questions from here. For diarrhea, I'm sure you have heard of this. This is loperamide, which is a mu agonist. So now we want to suppress the bowel movement, so use a mu agonist. So or you can use an enzyme inhibitor which blocks the metabolism of opioids. So this is enkephalinase inhibitor. So enkephalinase basically metabolizes opioid. So I'm inhibiting this, so more opioid will be accumulated. So this is racecodotril. So there are mainly 3 groups of drugs which are opioid agonist or antagonist basically, and important for you to remember. Okay, so this is about constipation and diarrhea drugs. Finishing off GI pharma altogether, vomiting again very important. Let's just finish the physiology also. So what happens is the brainstem vomiting center is what is regulating the vomiting response. Here the main receptors that you have are serotonin and D2 receptors, 5-HT3 and D2 receptors. So what I can do is I can just block these, isn't it? Whatever is the stimulus, it will be blocked, just like giving PPIs. So here we can use 5-HT3 blockers, and these are your citrons, ondansetron, granisetron, very important, and these are usually the drug of choice for post-op vomiting, post-chemo vomiting, or post-radiotherapy vomiting. Alright, so this is very important. Just one thing that you want to remember, this is for early onset post-op vomiting. In case they mention delayed onset, and this is particularly for cisplatin. Alright, so cisplatin is the most emetogenic anti-cancer drug that we studied in pharma as well. Remember that this is the drug of choice for delayed induced vomiting by cisplatin, and that is your NK1 or substance P inhibitor, which is aprepitants or your P-ant. So you can see that it is basically blocking the P-ant. Alright, so that is what you want to remember, that these are your expitant group of drugs which are for delayed vomiting. Everywhere else your answer becomes ondansetron or granisetron. The side effect would be headache, alright, so very common side effect. What is very important is QT prolongation, and because they are blocking the serotonin in the intestine, they are going to have constipation. Okay, I can also use D2 blockers. So D2 blockers would be metoclopramide and domperidone. So these are very commonly used. What you want to remember here, extremely important, is that metoclopramide crosses the blood-brain barrier, whereas domped does not cross the blood-brain barrier. Metoclopramide can have side effects such as extrapyramidal symptoms because they're blocking the D2 centrally, and they can also induce hyperprolactinemia. So this is just like your antipsychotic drugs which block D2 centrally, okay? Whereas domperidone is not going to have such effects. Metoclopramide is also a 5-HT4 agonist, and that is why this is a prokinetic which can be used in gastroparesis. Very important. So metoclopramide is also a prokinetic. So you want to remember everything is pro in metoclopramide. It pro crosses the blood-brain barrier. It is a prokinetic, alright, whereas domped does not cross the blood-brain barrier, and this is the drug of choice for levodopa-induced vomiting. Okay, so this is for levodopa induced vomiting. We will use domperidone. Okay, so this is about the main central blockers. Apart from that, what are the stimulants? So basically any drugs, hormones like we have seen are going to act via area prostema, which is the chemo trigger zone, which will stimulate vomiting. So for this, what is the drug of choice? As we have already seen, it is 5-HT3 blockers, that is ondansetron. Then we can have motion which can stimulate the cerebellum, or you can have gag reflex or the stomach which acts via the nucleus tractus solitarius and promotes vomiting. So remember, pharyngeal stimulation is via glossopharyngeal, whereas gastric stimulation is via the 10th cranial nerve. Okay, so this is how the vomiting physiology happens. Finally, the drug of choice for specific things like morning sickness. So in pregnancy, we can't give a lot of these drugs. The drug of choice is going to be doxylamine along with pyridoxine. Alright, so that is what is frequently given to females with very refractory morning sickness. Okay, for mountain sickness, the drug of choice is acetazolamide. Alright, so this is very important. Acetazolamide also causes acidosis. So what is the pathophysiology here is that when you go to high altitude, so mountain sickness or high altitude sickness, basically you're going to have hyperventilation. So because of that, a lot of CO2 washout happens. There is respiratory alkalosis, and to counter that, we want to give acetazolamide. Like I've taught you in renal, we want to induce metabolic acidosis. Okay, so that's also one reason of giving acetazolamide. For seasickness, the drug of choice is antihistaminic, which is meslizine. And for motion sickness, it is actually hyoscine. Alright, so we are going to give hyoscine. So these are 4 independent group of drugs that we can also give for vomiting, which are mainly working via anticholinergic or antihistaminic mechanism. Okay, so this completes pharmacology for us. Now straight off jumping into core medicine topics. And if you take the medicine of GI hepatobiliary, you will see every year one question coming on ascites, particularly in INICT. They love to ask you about SAG. So what is SAG? Is serum ascites albumin gradient. So we are taking a gradient between serum and the ascites. Alright, so here the transudative exudative concept of pleural effusion doesn't work. We need to rely on the SAG. So what we are doing here is we are measuring the serum albumin, we are measuring the ascitic albumin. If the gradient, so now we start off with medicine part of GI. Alright, so what you will realize is a bulk of the topics we've already covered in surgery. When we're doing GI, a lot of path gets covered simultaneously. So in this particular module, what I'm going to focus on are core niche medicine topics, and the most important out of them is ascites. You can't go to any exam without doing this, because nowadays, particularly INICT loves to ask you about SAG. Alright, so what is SAG is how we approach ascites. So any ascites, now we don't look at it as transudative, exudative like we do with pleural effusion. We calculate this measure, that is SAG, which is the serum minus ascites albumin gradient. Okay, so we look at the SAG. Any SAG which is lower than 1.1 means that the portal pressure is low. So the easy way to remember this is, and not get confused, is SAG is directly proportional to the portal pressure. Higher SAG means we are dealing with portal hypertension, lower SAG means it is not portal hypertension. Alright, so that's the first step. Now when it is not portal hypertension and the gradient is less than 1.1, it could either be that serum albumin is low, like something like nephrotic syndrome, or that the ascitic albumin is high because of some sort of exudative conditions. So how we approach it is we look at the clues given in the question. If they talk about frothy urine, likely they are talking about nephrotic syndrome, right? In nephrotic syndrome, the SAG is going to be low. Whereas if they talk about fever, weight loss, you start thinking in terms of infection, most common being TB. So again, the ascitic albumin increases in TB. Weight loss, elderly, start thinking in terms of malignancy. Acute pain, start thinking in terms of pancreatitis. So all last three of these causes are going to have high ascitic albumin. Got it? If the gradient is more than 1.1, our diagnosis is clear, which is portal hypertension. Repeat Ames question. If they say that the ascitic protein is lower than 2.5, overall total protein is lower because the smaller proteins like immunoglobulins and because other proteins as well apart from albumin are not able to be filtered, and the reason is going to be end stage liver disease, that is cirrhosis. So remember that in cirrhosis, overall ascitic protein is going to be lower, whereas if it is high, then we start thinking of conditions which are upstream from the liver, such as Budd-Chiari syndrome, in which you have outflow obstruction, so hepatic veins are blocked here, or IVC is blocked in Budd-Chiari syndrome, or other causes could be constrictive pericarditis or restrictive cardiomyopathy. So cardiac causes basically which are increasing the sinusoidal pressure. Okay, so this is about the approach to SAG. If the ascitic protein is high, you remember that it's causes upstream to the liver, whereas if ascitic protein is low, it is cirrhosis. Okay. Now talking about this Ames question wherein they had asked that at what volume you will have different things. So remember, ultrasound can pick up anywhere close to 50 ml of fluid. Alright, so for a safe range, you want to remember 50 to 100 ml, and this is the same range that we remember on FAST also. Okay, for eFAST, how much fluid it can pick up? It's around 50 to 100 ml. Alright, so here 50 would be a better answer for ascites. Alright, then when we talk about shifting dullness, remember we can pick up fluid around 500 ml. It would need 500 ml of fluid to be eliciting shifting dullness, and to elicit fluid thrill, when you basically percuss, you see the fluid thrill. For this, it requires 1500 ml. Okay, so you can remember 50, add a 0, 500. Multiply by 3, 1500 ml is going to be fluid thrill. Okay, then let's talk about the management. So management is going to be dependent on whether the ascites is mild, moderate or severe. Mild is when the patient does not have any clinical feature, it is just the ultrasound which has detected the ascites. So here what you do is just salt restriction. Alright, so salt restriction is the first line thing that you would do if it's only mild ascites. If it is moderate ascites, meaning ultrasound is also showing and you have clinical features of abdominal distension as well. In this case, the drugs that would be the first line is furosemide. If it does not respond to it, we give potassium sparing diuretics like spironolactone. Because spironolactone has refractory gynecomastia, in order to prevent that, we can also give eplerenone. Alright, so spironolactone or eplerenone is what is to be given, basically furosemide followed by potassium sparing diuretics. In case of severe ascites, and this is defined as the presence of respiratory distress, if the distension is so much, patient starts to have respiratory distress, here the management is going to be high volume paracentesis. So a quick word about high volume paracentesis. So here frequently fluid more than 2.5 liter is removed from the intestine, and when you do that, you also have to give albumin supplementation. Alright, so albumin supplementation, remember it is 6 to 8 grams per liter of fluid which is removed. Alright, so this is the volume that you want to remember. Okay, so this is about all of the points which can be tested from ascites. Now let's talk about diarrhea. Again, one slide compiling everything that you need to know. The first part is acute diarrhea. diarrhea. Definition wise, any diarrhea which is less than 2 weeks is acute diarrhea. Any diarrhea which is more than 4 weeks is chronic. In between, we have persistent diarrhea for 2 to 4 weeks. This nomenclature is slightly controversial. In the exam, don't stress too much about it. It's basically all of these buzzwords that is going to get you the answer, okay? So, whenever we're talking about acute diarrhea, remember, here the presentation, if it is less than 6 hours, so you had some food and less than 6 hours you start to have vomiting and diarrhea, what do you suspect? So if Chinese food is the history, here it's not really diarrhea, it's here just so that you can compile or food poisoning. It is more commonly the emetic type or the vomiting which predominates, and the cause you want to rule out is Bacillus cereus. We've also talked about this in micro. If you remember, I gave you cross pneumonic, MYPA and PLET, Chinese plate I told you. So PLET medium was for B anthracis, whereas for B cereus it was MYPA. I hope you remember that. So this is B cereus. If history of dairy is given, it is staph or yes. So these are the two causes only which are gonna present in less than 6 hours, and that is why this is so important. You always get questions on this, okay? But if the diarrhea is more than 6 hours, look at the buzzword. If it is a traveler being mentioned, then you look at ETEC, enterotoxicogenic E. coli. T and T. Here you have heat labile toxin and heat stable toxin. LT toxin, if you remember, the very first thing I've taught you in micro, increases CEMP, whereas the ST toxin. So these are the toxins for ETEC. Then when we have history of rice water diarrhea, it is Vibrio cholera that you want to remember. So this is Vibrio cholera. Shellfish history being given. So this is Vibrio parahemolyticus that you want to keep in mind. If there is history of camping or there is persistent diarrhea or malabsorption, the only infective cause of malabsorption, this is Giardia. I hope you remember angry uncle with 2 nuclei, 8 flagellae, 4 anterior, 4 posterior. Yeah. So here we have the trophozoite. This was the trophozoite which I love drawing. I hope you do too. So this was the trophozoite, which is the diagnostic form, but the infective form is the cyst, isn't it? So this is Giardia. Acute right iliac fossa pain. So which infection can mimic appendicitis? That is Yersinia. Yeah. So Yersinia pseudoappendicitis is what is the name. If there is history of antibiotics and then you have diarrhea, what do you think? Think of Clostridium difficile. So frequently in admitted patients, you will have pseudomembranous colitis. If there is bloody diarrhea, meaning dysentery and history of poultry and eggs is there, you consider Salmonella. If there is severe dehydration or fever as high to cause febrile seizure, then you remember Shigella. Alright, so Salmonella, Shigella. If there is associated buzzwords of Guillain-Barré or Ritter syndrome, think of Campylobacter. Again, from microbiology, all of these are basically going to be revision of micro. You want to remember hot campfire. So this grows in hot temperature and the medium was Skyros. Yeah, you remember hot sparrow. So this is Skyros medium. If there is history of uremia, anemia, you start to think of hemolytic uremic syndrome. O157H7 strain of EHEC. Yes, and you also want to remember that this strain and Shigella have the same mechanism and they act by inhibiting the 60S ribosome, isn't it? Flask-shaped ulcers, if it's given, consider amoebic ulcers. So entamoeba histolytica. If longitudinal ulcers are mentioned, think typhoid, whereas transverse ulcers are T for TB. So you want to remember out of these, it's the transverse ulcers which are stricturing and not the other two, okay? So in amoebic dysentery, they can also give you history of associated amoebic liver abscess, anchovy pus sauce could be mentioned. So all of these are your differentials for diarrhea. So this is basically infective diarrhea in a nutshell. Now coming to the core topic, if there is chronic diarrhea, what you want to rule out is basically malabsorption. Yes. So here the first step is something known as a stool osmotic gap. You want to measure the stool osmotic gap, whether it is a secretory diarrhea or an osmotic diarrhea is the approach that we want to take here. So the formula here is you take stool sodium and stool potassium. This would be given to you in the question. Take a sum, multiply by 2 and subtract from 290. If it is less than 50 means it is secretory diarrhea. Alright. If it is high, it means it is osmotic diarrhea. One more way of distinguishing is that if it resolves on fasting, It is osmotic, all right. So osmotic is the diarrhea which also reduces on fasting, whereas secretory is going to have no change. So these are two methods, one stool osmotic gap, other they could mention in the history about fasting and the change, okay. So if it is secretory diarrhea, two causes would be Zollinger-Ellison can cause and carcinoid syndrome. These are two causes of chronic secretory diarrhea. Coming to the most important part, that is osmotic diarrhea. The stool osmotic gap is high. So here the approach would be, first off, if they're talking about positive hydrogen breath test, what you want to rule out is lactose intolerance. Alright, so lactose intolerance would be the most important DD for osmotic diarrhea. Then if the center point is around fat malabsorption, then we go into the story of malabsorption. So are you seeing the stepwise approach? If it is secretory, you consider Zollinger-Ellison carcinoid. If purely osmotic based history is given, hydrogen breath test being mentioned, think of lactose intolerance. If malabsorption is the main story, they are saying that there's a young boy who's having these greasy stools, and they can also mention the deficiency of fat soluble vitamins like A, D, E and K. This would be the line of history. In that case, our approach is centered around the D-xylose test. So what is the D-xylose test is, I ask this person to drink this radioactive D-xylose. Alright. So what I ask this person, the patient, is drink this D-xylose if you have proper absorption. There is obviously going to be high excretion in the urine because every step is happening, it's getting absorbed from the intestine and it's coming out in the urine and not in the fecal excretion. So if that is normal, if you have excretion of D-xylose in the urine, means absorption is not a problem. In that case, the cause of fat malabsorption can be localized to pancreas. Alright, so how did we do that is, pancreatitis or pancreas is the organ which is responsible for only fat absorption and it has nothing to do with carbohydrate or D-xylose. So that's why it remains normal. So when D-xylose comes out to be normal, our differential becomes pancreatitis as the cause of stool fat malabsorption. But when D-xylose is positive, or I can say it's abnormal, there could be various causes. One could be in the intestine, you have box. What is box? It is bacterial overgrowth syndrome, also known as SIBO, small intestinal bacterial overgrowth. So here, in this condition, because of some sort of stricture or maybe functional motility problem like diabetes, you have this stasis, alright, and there you have overgrowth of the bacteria. So this is one cause. The other cause is some sort of mucosal disease such as celiac disease or A beta lipoproteinemia or tropical sprue. So how to distinguish? There are two differentials. So what I do is I give a trial of rifaximin for 7 days. If the person responds, now the D-xylose becomes normal, that is because of box, because I could treat that with this rifaximin, which is antibiotic, whereas if it still remains abnormal, then it is mucosal disease. And how to approach mucosal disease? Biopsy. Biopsy is the investigation of choice. So I'm going to show you two path images. We go directly into path. Two main causes of malabsorption which are mucosal can be asked to you as image-based question. So here this is an image of normal villi of the small intestine and this is our pathology. So what you see here is that there is flattening of the villi. Can you see this? That the villi are flattened, and look at the crypts. There is crypt hyperplasia. So what you want to remember, at the top, the villi, there is villus flattening, but there is associated crypt hyperplasia. So when you see this finding, in addition to a lot of lymphocytes in the lamina propria, here what you are having is celiac sprue. So what happens in celiac sprue? It's an autoimmune disease, HLA-DQ2. This is a repeat question. Most commonly affects the duodenum. So that's the site of the biopsy that you want to do. And because you remember iron fist bro, frequently these patients are going to present with iron deficiency anemia. Okay, so you're going to have short stature, iron deficiency anemia in the patient. You will be shown the biopsy showing you villus flattening, crypt hyperplasia and a lot of lymphocytes in the lamina propria. You think of celiac sprue. What happens here is that you have hypersensitivity or basically cell mediated immunity getting activated against gliadin. Alright, so gliadin is the antigen which is present here, against which you're going to have CD8 T cells which are present in the lamina melanocortina propria. Okay, and that is why you want to remember that this is a risk factor for enteropathy associated T cell lymphoma. So you have to monitor these patients for T cell lymphoma in the future for the intestine. Okay. So how do you treat celiac sprue? You just avoid gluten agents. So this is gluten which is giving rise to this gliadin. Alright. So you want to avoid gluten in the diet. So that is going to be the treatment, that you avoid these agents which are rich in gluten, that is brow. So barley, rye, oat and wheat is to be avoided. They can have rice basically is what you want to remember. Okay, so this is about it. One association we have studied it in derma as well is dermatitis herpetiformis, in which the treatment is going to be dapsone. You're going to have IgA which comes there in the papillary tips. Okay, so this is about celiac sprue. What you want to remember about this pink thing is your PAS. All right, also we'll talk about it in general path. So this is your PAS positive bacteria here, which is Triopherma vipelli. So what we are talking about is Whipple's disease caused by Triopherma vipelli. The sentence that is going to help you here is pass the can of whipped cream or whipped foam. So pass the can of whipped foam. How does that help me? First, I know it is PAS positive, and also remember it is diastase resistant. Everything except glycogen is diastase resistance. Whipped foam because vipelli. Why foam? Because on histopath you are going to have foamy macrophages. Okay, so foamy macrophages, this is an electron microscopy showing you the bacteria here. Why can? So from can you remember the other manifestations of Whipple's disease. C for cardiac involvement, A for arthralgia and N for neurological involvement. Alright, so this is the triad of findings in addition to malabsorption. One repeat question, they had mentioned foamy macrophages in the intestine and then they said acid fast bacilli. So obviously this becomes GI-TB. So GI-TB also has foamy macrophages and Whipple's disease also has foamy macrophages. You want to remember that. Okay, so this is about Whipple's disease. Now let's go to the very important IBD. Technically, you would study this in path, a surgeon would also teach you, a medicine faculty would also teach you, radio faculty would also teach you, like I have in my radio lectures, but now we bring it all together once and for all. Alright, so this table tells you all of the things that you want to know from the basics to the advanced about inflammatory bowel disease. So two common types, we have ulcerative colitis and we have Crohn's disease. So the wall layer which is involved in ulcerative colitis is the superficial layer, that is mucosa, whereas Crohn's disease is transmural. The most common site of UC is going to be rectum. Remember, rectum is invariably involved and that is where the disease always starts. Whereas in Crohn's, it is the terminal ileum which is the most common site. Talking about strictures, fistula and abscesses, they are more common in Crohn's disease as compared to UC because it is transmural. You can remember because all layers are involved, higher chance of stricturing fistula and abscesses. Where do you have skip lesions? Again, they are there in Crohn's, whereas ulcerative colitis is continuous involvement. You're going to have continuous involvement from the rectum towards the colon. The antibody in UC frequently associated with P-ANCA or atypical P-ANCA, whereas in Crohn's it is anti-Saccharomyces cerevisiae, ASCA. Alright, so you want to remember C for Crohn's here. Okay, then what is the histopathological hallmark of ulcerative colitis? It is crypt abscess. Remember, they can be seen in Crohn's also, but if asked, they are the hallmark of UC. The hallmark of Crohn's disease is the presence of non-caseating granulomas. Very important. So when you see transmural inflammation with granulomas, always rule out Crohn's. Imaging finding wise, on the barium images which were traditionally done, UC shows you this mucosal granularity as the earliest finding, and eventually you are going to see that all of the hostria are gone and you have this ahostral lead pipe-like appearance. On the other hand, Crohn's disease, the earliest imaging finding is what is known as aphthous ulcers. You're going to start seeing these aphthous ulcers early on. Eventually, what's going to happen? They are going to merge with serpentine ulcers and form this cobblestoning appearance. Okay. The classification system for UC is what is known as true, love, Witt classifications. You want to remember true, love, Witt classification, whereas for Crohn's disease, it is known as the Montreal classification. Okay. Previously, there was a Vienna grading as well. Now we are using Montreal. For UC, remember the management is going to be medical management as first line management. What you want to give these patients is 5-ASA, which could be in the form of sulfasalazine, which has sulfanpyridine associated with it, or it could be osalazine, which has an azo bond. Alright, so we basically want to protect this 5-ASA from getting degraded in the intestine and reaching till the colon. Alright, so that's why we are adding these additional compounds. So basically 5-ASA, if it doesn't respond, the next line is steroids. If that doesn't respond, we go for surgery. The surgery here, because it is continuous, is going to be total proctocolectomy. So total proctocolectomy is what is done, followed by an ileal pouch anal anastomosis. So you create an ileal pouch and anastomose it with the anal canal. Alright, so this is the surgical management. As far as Crohn's disease is concerned, the first line is steroids. If this does not respond, we have to switch to biologicals. Alright, so TNF antagonist, like we studied in RA also, will come into picture here. Okay, so surgery is not the mainstay in Crohn's because there are skip areas, different parts of the bowel are involved. So surgery is not something that you would want to do upfront. Okay, so this is about the management aspect. To look at all the radio and path images, so this is what I was talking about. This is the mucosal granularity, and you can see how the hostria are absent on the barium enema. So this is known as the lead pipe colon along with mucosal granularity. On histopath, what you are seeing here is this pseudo polyps appearance. So we are going to have pseudo polyps here because of the superficial involvement, and this is the histopathological hallmark, which is crypt abscess. So these are all of the findings of UC. On the other hand, what you see here is a terminal ileal stricture, which is known as the string sign. On CT, you will see a lot of inflammation. So the vasa recta open up, and this is what is known as the comb sign. The histopathological hallmark here is transmural involvement with the presence of these non-caseating granulomas, like you can see, and this is the cobblestoning appearance of the intestine, wherein you have all of the aphthous and serpentine ulcers coming together. So these are all findings of Crohn's disease. Okay, so this takes care of IBD for us. Apart from this, one question comes about the extra-articular manifestations. Which of these respond to the primary treatment of IBD? So peripheral arthritis will respond, but axial spondyloarthropathy is a manifestation. Axial arthropathy, spine, does not involve. Okay, then erythema nodosum responds, but pyoderma gangrenosum doesn't respond. So both of these are cutaneous manifestations. So EN responds. Erythema nodosum are these tender lesions on the shin. Again, we have discussed this in derma. Pyoderma gangrenosum is going to be again present most commonly in the shin, and you have these very necrotic sort of appearance, and you have neutrophilic infiltration on histopath. Episcleritis is the ophthalmological manifestation which responds, but uveitis doesn't respond. So you can see how everything correlates, and also very, very important, primary sclerosing cholangitis doesn't respond. Okay, so this is multifocal biliary strictures, which can be an extra-articular manifestation. That is something that does not respond. Okay, so this takes care of this. Now we go on to something very, very important in path, which is about GI polyps. So in GI polyps, what you want to remember is we have non-neoplastic and we have neoplastic polyps. Non-neoplastic, the most common ones which I am showing you here are the hamartomatous polyps. Alright, so remember, hematomatous polyps are the most common types. What you're gonna see here are these serrations. Can you see these serrated margins on an axial section here? If these serrations are only in the top 1/3, that is hematomatous. If it extends throughout the thickness, then you have to rule out serrated sessile adenoma. Rule out SSA, which is serrated adenoma, which is again a neoplastic sort of a polyp if there is full thickness serrations. Okay, so this is hematomatous. If you start seeing inflammatory cells, can you see this lymphocytes and all of the inflammatory cells? You have history of rectal bleeding and mucus discharge. This is inflammatory polyp. Okay, so inflammatory polyp, remember, also known as solitary rectal ulcer syndrome. Okay, so this is the clinical counterpart of inflammatory polyps. Then where you get questions from are the hematomatous polyps. So what are the hematomatous polyps? Again, remember, these are non-neoplastic. Hematoma is not malignancy, it is disorganized tissue. Okay, so when they give you a child, a 4-year-old with rectal bleeding, and look at this, this is the hallmark, you start to see cystic spaces within the polyp. This is what is the hallmark pathologically. 4-year-old young child, this is how you are going to identify this as juvenile polyp. From 4-year, you want to remember the gene here is SMAD4. If there are multiple, that is known as juvenile polyposis syndrome. Okay, so very important, rectal bleeding in a child, 4 years, SMAD4, cystic spaces within the polyp. The most important, if you don't know anything, you mark Peutz-Jeghers syndrome. So what you are seeing here is this very typical arborizing pattern of the polyp. So arborizing, it looks like a tree, isn't it? And you have this smooth muscle which is going into the polyp. Apart from that, you're gonna get this mucocutaneous pigmentation around the mouth, very, very typical history. 11-year-old with intersusception. Why intersusception? Because these polyps can act as a lead point for intersusception to occur. Okay, so this is Peutz-Jeghers syndrome, very, very important. 11-year-old child usually will present. The importance of this, you can remember one more thing is the mutation STK11-LKB1. Alright, so STK11-LKB1 you can remember from 11-year-old presentation. Okay, and you want to remember Peutz-Jeghers has the highest risk of pancreatic adenocarcinoma. Okay, so pancreatic adenocarcinoma, it has 100% increased risk. Okay, very, very important. Coming to the neoplastic polyps, you either have the tubular type like I'm showing you here, or you could have the villus type. It's the villus type which has higher risk of malignancy. Okay, this is about all of the polyps. Apart from that, I have also included 2 more syndromes of hematomatous polyps that you want to know. One is Cowden syndrome, where you have P10 mutation which can have hematomatous polyps. In addition, in Cowden's, what you remember is 3 malignancy. So from P10 you remember BET. Sounds like P10. So BET, you have breast, you have endometrial and thyroid CA, which are increased in risk here. In addition, there are also lesions which are known as tricholemomas. Alright, so there are going to be hair-based lesions which are known as tricholemomas here. In Cronkite Canada, the most important thing is this is not inherited. Alright, so this is not inherited. In addition to polyps, you're going to have all of the ectodermal derivatives having problems. So you're going to have alopecia, nail having problems, skin having problems. So all ectodermal derivatives have a problem in Cronkite Canada. Okay, so this is all about polyps in one slide, which is actually a 1.5 hour talk in itself. But these are the most important takeaway points. So remember, most common is hematomatous. You will see the serrations. Then you have inflammatory, which is solitary rectal ulcer. In hematomatous, juvenile polyp, most important Peutz-Jeghers, Cowden and Cronkite Canada. In neoplastic, we have tubular and we have villus, or we can have tubulovillus as well. Okay. Now let's talk about very, very important image, Robbins. This is adenoma carcinoma sequence. You gotta know the mutation. So this is for normal adenomas or your tubular or villus adenomas. This is known as AK53 is what you want to remember. So the first hit here is APC. So this is the germline or somatic mutation, the first mutation which occurs at 5q21. Very, very important. So this is familial adenomatoid polyposis. This is autosomal dominant. Remember APC at 5q. After that, you have APC beta catenin second hit which is happening. Then you have K for KRAS mutation at chromosome 12. All chromosomes are important. So 5, 12, and then you have P53 at 17. Alright, so you can remember 5 plus 12 equals 17. Okay, apart from that, you can have other mutations as well. So the sequence is what is asked. So you just remember AK53, 2 hits of APC followed by KRAS followed by TP53. SMAD2 and 4 can also be associated, that we also saw with juvenile polyp, right? Then, when you have sessile serrated adenoma, or basically when we are talking about hereditary non-polyposis colon cancer, you want to remember this. I've also talked about in biochemistry in DNA mismatch repair issue. So this is where you have problem with the mismatch repair genes. So these are the genes, the two most important ones, 1 and 2, MLH1, MSH2. These are your mismatch repair genes which are going wrong. Following that, you can have TGF beta receptor 2, BAX, BRAF and other mutations. Okay, so this is about HNPCC as well. Then just as we're talking about BRAF, here you want to remember other tumors also with BRAF. So melanoma, colon we've already seen, PAPCA thyroid, hairy cell and LCH. And all of these, you know, we now have direct BRAF inhibitors which are dabrafenib and vemurafenib. So just remember this for extra H for INICT. So this is adenoma carcinoma sequence. One more thing you want to remember are associations of FAP. So you want to remember Gardner syndrome. Gardner syndrome is where you're going to have a lot of, again, ectodermal layers getting affected. So you can have supernumerary teeth here. You can be given a radiological image of an osteoma. There could be abdominal wall fibromas which are associated. There is congenital hypertrophy of retinal pigment epithelium which could be seen. So these are all Gardner syndrome manifestations. And then you have Turcot syndrome, in which you have Turcot-se-Turban brain lesions. So brain tumors, medulloblastoma and glioblastoma multiforme are frequently associated. Alright, so this is about the adenoma carcinoma sequence. So now talking about biliary pathologies, two conditions you want to contrast: primary biliary cirrhosis from primary sclerosing cholangitis. So first is a histopathological image of PBC. The hallmark are these inflammatory lesions known as florid lesions around the ducts, whereas in primary sclerosing cholangitis, you're going to have this onion skinning appearance around the bile duct. Okay, so this is the histopathological difference. Radiologically, PBC remains normal. Here the MRCP is going to be normal, whereas in PSC you would see that there is this beaded appearance. You can see multifocal strictures and dilatations. This is known as the beaded appearance of primary sclerosing cholangitis. Talking about the demographics, remember in PBC, you're going to have a young female who's having jaundice. More importantly, she's going to present to you with pruritus. Other associations could be the presence of xanthelismas and osteopenia. The most important hallmark is the presence of anti-mitochondrial antibody, which is AMA, which you have to rule out. Very, very important. On the other hand, PSC, you're usually going to have an elderly male patient who has associated IBD in the form of UC or Crohn's disease, who's presenting to you with jaundice. So this is about PBC versus PSC. Then there are certain niche pathology images from liver that I want to show you, which are all independent repeat questions. So in the first image, what they're going to talk about is alcoholic patients. So here we are talking about alcoholic hepatitis. What are these bodies which are going to show you cytokeratin 818 positivity or intermediate filaments? Very, very important. These are Mallory-Denk bodies. Alright, so these are Mallory-Denk bodies. Multiple times as repeat question, can be seen in other pathologies as well, like Indian child cirrhosis. But what you want to remember is alcoholic hepatitis. While we're talking about alcoholic hepatitis, remember AST by ALT. AST, which is at least 2 times higher, goes in the favor of alcoholic, whereas ALT being higher goes in the favor of viral hepatitis. So how you want to remember is toast. You want to raise a toast to alcoholic hepatitis, that is AST higher. We have also remembered AST toast in the OT. I hope you remember this from biochemistry. So this is SGOT. And this is the reaction. So once you know this, the reaction transamination is very clear. It is aspartate to oxaloacetate, which is reversible, and the cofactor is pyridoxine for all transamination, whereas it is ALT to SGPT. So alanine to pyruvate is the other transamination reaction. Okay. Apart from that, one more repeat question is Madry's discriminant function in alcoholic hepatitis. If it becomes more than 32, that is an indication of steroids. Okay, so that's just one line that you want to remember. If they show you hepatitis C infection, two named things you want to remember. These are councilman bodies, which are apoptotic bodies. Repeat question. Another thing you see in HCV is this portal tract expansion. Because of the inflammation, you can see the portal tract expansion. So these are two terms you want to remember which are specific with HCV. On the other hand, when you see a cell which looks like it has eaten up a lot of cells, this is known as emperipolysis. Repeat M's question. This is known as emperipolysis, which is basically the eating of one cell by the other, and the other hallmark here is this interface hepatitis. You can see this vessel with inflammation. So this is interface hepatitis, and what I'm talking about is autoimmune hepatitis. Here you're gonna have anti-smooth muscle, anti-LKM1. These are the antibodies which are associated, which I've given you as a exhaustive list in RUMAT system. Okay, so this is about all of the path images that you want to know. Talking about specific medicine aspects about various complications of cirrhosis. So first is hepatic encephalopathy. Remember, the earliest symptom here is going to be an altered sleep cycle. So this is the symptom here, whereas most commonly they ask you the specific sign, which I'm showing you as an image based question. So what is going to happen here is when the examiner gives this resistance, there's going to be this flapping tremor, which is known as asterixis. Alright, so I'm just going to take a moment here and show you this as a video also, because that is something that I expect the future to be. You can be asked questions on this. So look at this video here. When the examiner is basically doing this resistance, you have this flapping tremor, and this is what is known as asterixis. Alright, so this is what is being demonstrated here. You want to keep this in mind. Look at this one more time. Alright, so this is about hepatic encephalopathy. Now going on to the EEG finding. So what you're gonna get on EEG in hepatic encaph is triphasic waveform. So this is very, very important. In the end stage, you will have delta waves or slow waves. The staging is known as the Westhaven. I don't think you need to know the details. You can just Google it once if you want. It's the Westhaven grading for hepatic encaph. Now when I give you SAG is more than 1.1, means portal pressure is high. So obviously we're talking about cirrhosis, and they give you a cytic neutrophil of more than 250. Very, very important. We're talking about spontaneous bacterial peritonitis. You have to keep this number in mind. The moment you hear 250, mark SBP. Spontaneous bacterial peritonitis. They frequently ask you the drug of choice. Drug of choice here is cefotaxime. Okay, so this is about SBP. Then if they give you AKI in a patient with cirrhosis, acute kidney injury, and you know from renal that the fractional excretion of sodium is less than 1, means they're talking about a pre-renal form of AKI. So this is hepatorenal syndrome. Remember, hepatorenal syndrome is a type of pre-renal AKI, and what also helps you here is that there is no sign of shock. So hypovolemia being the most common cause of pre-renal has been ruled out. So then you land up at a diagnosis of hepatorenal syndrome, and what you want to remember here is the treatment. The drug of choice is going to be terlipressin in addition to albumin is what you have to give this patient. If they give you this typical history of platypnea and orthodeoxia, position-specific dyspnea. Here you want to think of hepatopulmonary syndrome. So these are your buzzwords for complications of cirrhosis, each one of these being an independent question. Two diseases finally, metabolic diseases. I've also talked about them here and there. So what you are seeing here are the KF rings. We have seen them in opthal. What is this? This is copper deposition in the Descemet's membrane versus Fleischer rings, which we had seen in keratoconus, which is iron deposition in the epithelium. Yeah. So this is KF rings, and what you are considering is Wilson's disease. So remember, in Wilson's disease, the mutation is in ATP7B on chromosome 13 versus ATP7A in Menkes kinky hair. Okay, so this is what you want to remember here. The ceruloplasmin levels are going to be low, so the copper is not bound and the urine copper increases. Very, very important. There is a prognostic indicator of Nazar that you want to remember, which includes three things. What are those three things? Could be a repeat question. So one is bilirubin, second is AST, and third is PT. So they can give you an all except question here, that all of the following are indicated in prognostic indicator of Nazar except. Okay, so you remember these three. You can remember BASP. Okay, for the lack of a better mnemonic. Remember, Wilson's is associated with type 2 renal tubular acidosis, very important. KF rings are associated, the percentages can be asked. So, in patients with neurological involvement, more than 90% patients have KF rings, whereas in hepatic involvement, only 50% have Wilson's ring. The treatment of choice is gonna be zinc here if hepatic decompensation is present. You also wanna add triantine to the zinc. Okay, so this is according to Harrison's. Okay, so this is Wilson's. On the other hand, if they show you either rad path appearance like this, in which on path liver biopsy, this is the Prussian blue, or the pearl stain, which is showing you what? This is a lot of iron deposition in the liver, and on MRI, look at this black liver. The liver is very, very black. This is one of the questions I've actually given in the radio Q bank as well. So this is your black liver because of iron deposition. All right, so this is the susceptibility of iron which makes it look black. So what am I talking about? We're talking about hemochromatosis. Here it is HFE gene on chromosome 6. You can also remember HLA. So HLA, HFE, three letter words with H are on chromosome 6. Here there is a problem with hepcidin, and that is why iron regulation goes wrong and you have high liver deposition. We did talk about hepcidin in the physiology part, isn't it? So what all organs can be affected? So liver would be affected, so you can have jaundice here. The pancreas is affected, leading to diabetes, right? So you can have diabetes mellitus. Endocrine function is also lost. Pituitary can be affected, which can lead to infertility in these patients. A repeat question. Skin, the iron accumulation would make it look bronze. So that is why this is known as bronze diabetes. Heart can be affected, very, very important, restrictive cardiomyopathy. And skeletally, you have pseudogout, and one specific manifestation of hemochromatosis is metacarpals, showing this hook-like projection. Okay, so I've tried and accumulated and compiled all of the information about these two very important metabolic diseases that you study here and there in a lot of systems. Okay, so this marks the end of GI and hepatobiliary. I have focused a lot on physiology and pharmacology here, and we've done the remaining topics which we have not covered in GI surgery. So I would highly recommend you doing surgery after this if you've already not done it, or if you have any control, do this system after surgery, revise it after surgery the next time around. So thank you so much, and I'll see you all in the next one.